The incidence of obstructive and central sleep apnea is approximately 40 to 50% in patients with heart failure. Of those, about 60% are obstructive and about 40% are central. So it's very common. Well, there's different risk factors for the different types. So for obstructive sleep apnea, obesity is very important. Older age group is very important, and it's predominantly seen in men. In terms of central apnea, it's seen in older patients, mainly with ischemic cardiomyopathy, who have lower ejection fractions and higher left ventricular filling pressures. And in both cases, fluid retention also contributes to it. So heart failure is a disease of fluid retention, and when you lie down at night, the fluid from your legs moves up into your chest and into your neck. And depending upon where it ends up, if it's mainly in your neck, it will aggravate obstructive sleep apnea. If it's mainly in your lungs, it will aggravate central sleep apnea. So those are the main risk factors. Well, we've only studied people with low ejection fraction, so-called HFrEF, or heart failure with reduced ejection fraction. So I can't really say very much about those with normal ejection fraction. But for the reduced ones, we know that even if you don't have sleep apnea, if you have heart failure, you sleep 1 hour less than the otherwise healthy population. So patients with heart failure sleep less. They only sleep about 5 to 6 hours a night rather than 6 or 7. And because they have sleep apnea, their sleep is very disrupted because they have to wake up in order to breathe. So if they have 500 episodes of apnea, they have to wake up 500 times. And as a consequence, they generally don't have very much deep, slow wave sleep or very little rapid eye movement sleep. So the sleep is fragmented and it's poor quality and it's short. The main result was that in the 731 patients treated, those randomized to get the ASV, or adaptive cerebral ventilation device, which is triggered by peak respiratory flow, had no significant difference in the composite endpoint of all-cause mortality, cardiovascular hospitalizations, new onset atrial fibrillation, and ICD discharges. There was no significant difference. And if we divided them into those with predominantly OSA and CSA, there was no significant differences in those groups either. In terms of overall mortality, there was no significant difference in the overall group and in the OSA group. In the group with central sleep apnea, there was a trend to lower mortality in those treated with the peak flow ASV device. However, the difference wasn't significant. The risk reduction was about 22%, but the p-value was 0.34, so it's not significant.